Hi, everybody, and welcome to this session as part of Kidney Week 2020 Reimagined. Thank you for joining us on this session entitled Critical Illness and Acute Kidney Injury in COVID-19. What have we learned? My name is Michael Hung. I'm a nephrologist at the University of Michigan, and I'll be one of your co-moderators, along with Dr. Anita Vijayan from Washington University in St. Louis, who will be the other moderator and who will provide a summary at the end of this session. Obviously, our lives have all been heavily affected by the COVID-19 pandemic over these last 7 months, in our professional lives as well. And many of us have been affected in particular by the pandemic with significant involvement with kidney injury. And so today we're going to have a chance to consolidate some of that knowledge and hear from some experts that have been on the front lines and learn from their experiences. First, we will have Dr. Kathleen Liu from the University of California at San Francisco. Dr. Liu is a professor of medicine and anesthesia in the divisions of nephrology and critical care medicine at UCSF. She also serves there as the medical director of the apheresis hemodialysis unit and the medical intensive care unit. Her research has done a great deal of research and has focused on AKI as well as ARDS and critical care nephrology. I can think of no better person than Dr. Liu to speak to us about our understanding now of the etiology and pathophysiology of AKI in COVID-19 disease. Following her, we'll have Dr. Marlies Osterman, who is a consultant in critical care and nephrology at Guy's and St. Thomas Hospital in London. She's also affiliated with King's College in London. She is an active member of the European Society of Intensive Care and also the current chair of the AKI section. Her clinical research interests include all aspects related to AKI and multi-organ support in critically ill patients. And for her talk, she will be taking us for a look inside the COVID-19 ICU. Thirdly, we'll have Dr. Miran Neljayan, who is a clinical associate professor of medicine at the LSU School of Medicine in New Orleans. He also serves there as the interim section chief of nephrology and also as the vice president of clinical affairs for home modalities at DaVita Kidney Care. His talk is entitled, What's Old is New? PD for AKI. Also something that many of us have developed some experience with through necessity during this pandemic. So looking forward to that. Thank you again for joining us.
Good afternoon. I'd first like to thank the organizers for this opportunity to speak to you about COVID-19 associated AKI, etiology, and pathophysiology. I have no relevant disclosures for this presentation. I would like to give a special thank you to Anita Vijayan, who shared her slides from a recent presentation on a similar topic at Washington University. So first, a disclaimer. This has certainly been a year where I think we've been deluged with information about COVID-19. And obviously, the information that I'm presenting to you today is contemporaneous with what's available to me at the start of October 2020. When you're listening to this talk in the future, there may be new information that may apply, and we may have a better understanding of the etiology and pathophysiology of acute kidney injury. I think what is clear now is that in the initial reports of COVID-19, the incidence of AKI varied widely from 0.5 to 39%. And this likely had to do with different countries of origin of these reports and differences in the overall types of patients hospitalized with COVID-19 in a variety of different settings. In the United States and the United Kingdom, this summary slide from NEFJC suggests that the incidence of AKI in the ICU is quite similar across those practice settings, ranging from 61 to 76%. Similarly, the number of patients in the ICU needing kidney replacement therapy, quite similar, ranging from 25 to 45%. And a substantial portion of patients with AKI go on to require kidney replacement therapy in the studies where this has been reported. Similarly, we know that the epidemiology of AKI for patients in this initial first wave had a couple of peaks. So you can see in this slide that there's a peak of AKI occurring early around the time of admission, and then a subsequent later peak of AKI occurring after day 8 of hospitalization. I think what's less clear at this point is how many waves of COVID-19 we'll ultimately see before we have an effective panel of therapeutics and a vaccine. As we know, in 1918, there were 3 waves to the influenza pandemic. We appear to be in wave 2 of the COVID-19 pandemic, and that wave may be waxing or waning depending on where you are. I think we also don't know if the etiology and incidence of acute kidney injury will be the same in all waves, and this may vary a little bit depending on how hard a setting is hit. And this is represented in this data from the multi-center Stop COVID study led by Shruti Gupta and David Leaf. What you can see here is that this study has broad geographical representation from across the United States. This study focused on COVID-19 in the early part of the pandemic in the spring. And what you can see is that across various geographical regions, the West, the Midwest, the South, and the Northeast, the median age of patients was similar with a male predominance. There were some differences with regards to the median number of comorbidities, as well as some variation with regards to the need of mechanical ventilation on ICU day 1. And this was associated with very different overall mortality by region, with the lowest mortality occurring in the West at 21.4%, and the highest mortality occurring in the hardest hit Northeast at 41.5%. Similarly, if you look at adjusted 28-day mortality, you can see that this varied widely by hospital site within this study. I'll comment that small sites that contributed less than 10 patients to this analysis were excluded, so this is not due to the large number of relatively small sites on the West Coast. And what we know in this study is that acute kidney injury was common, occurring in almost 43% of patients, and was associated with a significant increased risk of death. And when coupled with other conditions such as respiratory failure and shock, was associated with even higher rates of death. So again, as waves may be less severe, whether or not the incidence of acute kidney injury may become lower is unknown. So we're going to turn now to the question that we'll focus on for most of our time, which is, what is the etiology of acute kidney injury in COVID-19? And I've tried to represent here that the etiology is likely complex and somewhat varied by patient. I think we, as we'll talk about, need to think about what is similar and different about our patients with COVID-19 and how often etiologies may be common and where there may be subtle differences in etiology by specific patient within a cohort. There's been a lot of focus then on the pathogenic mechanisms of COVID-19 infection, and this comes from a nice review by Don Landry and colleagues focused on extrapulmonary manifestations of COVID-19. This highlights the viral entry mechanism of the SARS-CoV-2 virus, which, as we're all very familiar with, occurs via the ACE2 receptor. This may result in direct cytotoxic effects of the virus itself. Downregulation of the ACE2 receptor that is bound to the SARS-CoV-2 virus may lead to dysregulation of the RAS system, and this may in turn lead to tissue injury and remodeling, inflammation, vasoconstriction, and changes in vascular permeability. We believe that binding of the virus directly to ACE2 receptors on the surface of endothelial cells may lead to endothelial inflammation with associated decreased fibrinolysis and increased thrombin production. Finally, there's been a lot of interest in the dysregulation of the immune response by this virus. This results in T-cell lymphopenia and inhibition of interferon signaling, as well as a potentially hyperactive innate immunity system. There's been tremendous controversy about whether or not there's a true cytokine release syndrome or whether or not cytokine storm does not apply in this condition. There have now been a number of reports suggesting that cytokine levels are not especially high in these patients and certainly not consistent with the very high levels observed in other conditions that cause cytokine storm. Nevertheless, it's clear that that infection with SARS-CoV-2 is a pro-inflammatory state associated with increased levels of IL-6 and TNF-alpha, and that this may promote thrombosis and vice versa within blood vessels in the body. This then results in effects on a number of different organs in the context of COVID-19 infection, including the neurologic system, thromboembolic events, cardiac events, endocrine and dermatologic events. There have been a number of dermatologic manifestations of COVID-19 described now, gastrointestinal effects, as well as hepatic effects, as well as effects on our favorite organ, which may manifest either as acute kidney injury, proteinuria, or both, as well as the presence of hematuria, which has been described. So here's the bottom line of what I'm going to show you over the next 20 minutes or so. First, we should keep in mind that acute kidney injury may be mediated by other factors other than direct viral involvement. We need to keep in mind the usual suspect in our critically ill patients, and these may include hemodynamic instability and mechanical ventilation, as well as nephrotoxins. There's been a lot of interest in microvascular thrombosis as a pathogenic mechanism, and even the possibility of thrombotic microangiopathy, and I'll show you some data focused on this. Viral involvement may lead to podocytopathies, and specifically to collapsing glomerulopathy. And finally, there's been some data suggesting that renal tropism may correlate with clinical outcomes. So focusing first on clinical factors associated with acute kidney injury, this is data from Chan and Koka examining risk factors for acute kidney injury in a US and a Chinese cohort. And you can see here that although the incidence of these risk factors varies by base population, the risk factors are very similar and are factors that we know are associated with an increased risk of AKI in general. They include hypertension, congestive heart failure, chronic kidney disease, type 2 diabetes, and respiratory failure. Now, why such a difference in the incidence of these factors? This may be due to the fact that in China, the population that was hospitalized was overall not as sick as the population hospitalized in the United States. And again, in a study from New York focused on the first wave of the pandemic and examining the impact of acute kidney injury on outcomes, this study showed in a cohort of almost 10,000 individuals that COVID-19 was associated with a high incidence of acute kidney injury, and that in patients who had COVID-19, severe AKI was associated with significant higher mortality than COVID-19 negative patients who experienced severe AKI. And if we look at admission predictors of AKI in this cohort, we can see that, again, some of the usual suspects for AKI are found, including age, Black race, male gender, and diabetes mellitus. And some factors associated with COVID-19 are also found, including, for example, nursing home resident respiratory rate as a surrogate for respiratory failure, and neutrophil to lymphocyte ratio as a surrogate for lymphopenia, which is commonly observed in these patients. In another study examining the relationship of acute kidney injury to mechanical ventilation, what you can see here is that patients who required invasive mechanical ventilation on the right had a much higher incidence of acute kidney injury. In this case series, almost 90%, and almost a quarter of those patients required renal replacement therapy. If you look at the timing of mechanical ventilation and acute kidney injury, you can see that in many of the patients, the timing of the initial acute kidney injury diagnosis occurs after the time of intubation, so occurs on patients while they're receiving mechanical ventilation. And we know from a variety of studies that there seems to be tremendous potential for lung and kidney crosstalk in the context of acute kidney injury and the acute respiratory distress syndrome and mechanical ventilation. This is outlined very nicely in this slide by Hussein Saeed and colleagues in a nice review article, and highlights that there are a number of ways in which ARDS and mechanical stretch related to the use of the mechanical ventilator and positive pressure ventilation may affect renal blood flow, renal perfusion, as well as lead to endothelial dysfunction and inflammation. So a number of ways in which mechanical ventilation in ARDS may lead to kidney injury. Should say we also think that there's probably bidirectional crosstalk, and we may see crosstalk in the other direction. But today, for the purposes of today's talk, I'm focused on acute kidney injury and not on ARDS per se. In the largest case series, Muhammad and colleagues reported on causes of COVID-associated AKI in a cohort of 161 patients. And what you can see here is that in the majority of these patients, this was felt to be an ischemic injury related to hemodynamic instability. For a variety of reasons. I'll comment that here in a substantial number of patients, prolonged volume depletion was thought to be an important risk factor. This may be due to the fact that these patients often are admitted with high fevers and sometimes with significant diarrhea and poor PO intake, so they may start volume depleted. And early on in the pandemic, certainly in the context of concern for mechanical ventilation, we certainly tried to keep these patients relatively on the dry side, and that may have exacerbated volume depletion and is an area of evolving clinical practice. You can see that some patients also had toxic acute tubular injury, with a few patients having de novo glomerular disease, which we'll talk about in more detail on the next slide. And again, along with ischemic acute tubular injury, some patients felt to have simple prerenal azotemia, which presumably rapidly reversed. So what do we know from kidney biopsy studies? There have been 2 studies published in this area. So this is a study, again, from the New York area, focused on kidney biopsies in patients with COVID-19. There were 14 native and 3 allograft specimens evaluated in the spring of 2019. The median age of these patients was 54, about 3/4 were male, and the about almost 75% Black. About half of these patients had COVID-19 pneumonia, and half of them did not. And the indications you can see for kidney biopsy here were a combination of acute kidney injury and also nephrotic range proteinuria. And as you can see, there was a wide spectrum of glomerular and tubular disease in this cohort of patients with AKI and nephrotic range proteinuria. Specifically, as we'll talk about on the next few slides, there's a significant incidence of collapsing glomerulopathy observed, and then a variety of other pathologies, with acute tubular injury again being quite common. There was not in this study evidence of direct viral infection of the kidneys as a major pathomechanism of injury, and we'll talk about that more on the next slides as well. In another biopsy case series, this one from the New Orleans experience, 10 patients with COVID-19 underwent kidney biopsy, again, for similar variety of indications focused on AKI, proteinuria, and hematuria. This was a relatively severe cohort of acute kidney injury with 8 patients requiring dialysis. And the bottom line was that of these patients, all patients had varying degrees of ATN. 2 patients had thrombotic microangiopathy, and we'll talk about that more in the next couple of slides. One of these patients had FSGS with features of collapsing glomerulopathy. All of these patients had no evidence of viral particles identified via electron microscopy, and by immunohistochemistry, there was also no detectable virus in this case cohort. So focusing then on thrombotic microangiopathy in association with COVID-19, if you look in more detail at that report, one of the 2 patients had concomitant exposure to gemcitabine, complicating the ascertainment of the relationship of TMA to COVID-19 versus the gemcitabine itself. In a separate report from the same group, they described in more detail the other patient. This patient had evidence of alternative complement activation with elevated levels, for example, of the plasma C3b complement fragment. And this was characterized by extensive microthrombi, which you can see here in pink on PAS stain in the glomerulus at the upper right-hand corner of this picture. So some potential some potential for TMA as a mechanism for acute kidney injury in this patient population, though clearly more studies are needed to better define the frequency of this as a potential complication. There's been a lot of interest in endothelial dysfunction in SARS-CoV-2 infection, and this is a diagram sort of highlighting endothelitis as a mechanism leading to dysfunctioned and injured endothelium. And this may, of course, then be responsible for some of the microthrombi that may be observed in patients with AKI in the context of COVID-19. So I'm going to turn now for a few slides to the pathogenesis of collapsing glomerulopathy, which has been described now in several cohorts of patients with COVID-19. This is a nice slide highlighting the complex pathogenic mechanisms that underlie collapsing glomerulopathy. We know that some patients have genetic predisposition to collapsing glomerulopathy, with APOL1 being the gene most closely associated with this. We know that in particular, viral infection can be a predisposing factor, with a number of viruses, including now SARS-CoV-2, implicated as perhaps a second hit in a predisposed host, leading to collapsing glomerulopathy. Obviously, a number of other potential mechanisms as well, including medications, some systemic diseases, and acute glomerular ischemia, which may occur in a number of other diseases. So this is data from a patient who underwent kidney biopsy and was shown to have collapsing glomerulopathy. What this slide shows you is that this patient had significant acute kidney injury, and this was in association with elevated urine protein to creatinine ratio shown by the purple squares, as well as elevated urine albumin to creatinine ratio shown with the light pink triangles. So again, collapsing glomerulopathy has been described in the context of acute kidney injury with significant proteinuria. And this is just a visual representation from one of the papers showing you a number of glomeruli with this collapsing variant of sclerosis in a case series. And similarly, this is another paper just showing on electron microscopy in association with this collapsing glomerulopathy, the presence of tubular reticular inclusions consistent with this disease. So there's now been some work then also examining the relationship of collapsing glomerulopathy in patients with COVID-19 to APOL1 risk alleles. So this is a case series of 6 Black patients who had COVID-19 with acute kidney injury and proteinuria. They underwent both kidney biopsy and genetic testing. And what you can see is that all 6 patients had 2 APOL1 risk alleles. These varied a little bit by patient. This was associated with elevated levels of chemokines and immunoglobulins. There was no evidence of direct infection by the virus by a variety of techniques looking at the kidney biopsy. And what you can see is that these patients had significant AKI with a median serum creatinine of 6.5 and very significant proteinuria with a UPCR of 11.5 grams per gram of creatinine. These patients, not surprisingly, were quite ill, with 2/3 requiring dialysis and 1/3 dying, and only 1 of the 6 recovering over the course of the study. So again, highlighting some of the ways in which our more vulnerable populations may be, in fact, at higher risk for complications from COVID-19. So I'm going to turn now from biopsy series, to autopsy series. Obviously, we learned somewhat different things because these tend to be different groups of patients. This is a 26-patient autopsy series from China. Just want to highlight that the degree of acute tubular injury varied widely across these 26 patients. In a very small number of patients, segmental fibrin thrombi were observed, and in 1 patient, FSGS was observed. In the later part of this case series, there was examination of the biopsy material for corona-like virus particles, as well as for SARS-CoV-2 nuclear protein. And you can see down here at the bottom right that there is, in some cases, these are well correlated, and in other cases, these are not well correlated. And we'll talk a little bit more about these corona-like particles and what they might represent on some of the next slides. Similarly, in a 42 patient autopsy series of patients who died with COVID-19, um, uh, uh, this study showed that acute tubular injury was the main finding correlating with acute kidney injury in this cohort, where 94% of patients developed acute kidney injury and 8 patients received renal replacement therapy, so about a quarter of the cohort. Strikingly, the acute tubular injury was typically quite mild, perhaps a little bit out of proportion to the degree of acute kidney injury. A number of patients did have focal fibrin thrombi. One patient had FSGS. Again, consistently no virus detected by in the biopsy material itself. So this brings me to an important point, which has been conceptually this concept that although early on a number of investigators reported corona-like virus structures within the kidney on electron microscopy, it's become clear that not all of these crowns are coronaviruses. And in fact, in some cases, these represent coated clathrin pits and other known microvesical structures that are found in the kidney. So if you, in this nice article by Rufus and colleagues, they show a kidney biopsy from the COVID-19 era in panel A, where there's this beautiful structure that you could advocate as a COVID-19 particle. But the panel B, which has a very similar particle, is actually from 2019. And they then go on to show a number of types of organelles that could be mistaken for coronavirus particles in the kidney. So again, I think this is why you see a shift in the reports that we saw early on, which reported a tremendous amount of COVID-19 material in the kidney, and then later reports that are using immunofluorescence type techniques to consistently detect COVID-19 in the kidney. I'll comment that the other thing that may play into some of the differences observed in studies is also the timing of biopsy relative to the timing of infection. I've shown you over the course of this talk that COVID-19 associated AKI may occur relatively early in the course. It may occur a few days into the course of COVID-19 when we think viral loads are overall lower. And finally, in patients undergoing post-mortem autopsies, those patients typically have had disease for a number of weeks, are in the late phases of COVID, and likely have very low viral loads, and therefore may have less detectable virus in a number of tissues. So with regards to the renal tropism of SARS-CoV-2, this has been studied now by the German group in some detail. This is data from their New England Journal of Medicine letter where they examined the number of RNA copies of the SARS-CoV-2 virus, examining the lung and the pharynx as very high density tissues. What you can see here is that compared to the lungs in particular, levels of SARS-CoV-2 per cell are lower, in the kidney, liver and heart, and even lower in the brain and blood. They went on to do in situ hybridization, to examine rates of, SARS-CoV-2 virus positivity in the lung and the kidney. And what you can see is that there is in fact detectable virus in both tissues, though the staining is likely less intense in the kidney compared to the lung. And similarly, if you do immunofluorescence, using DNA probes to hybridize to SARS-CoV-2 nucleic material, you can see that this material is detectable in the glomerulus and the tubule of the kidney, as well as in the lung at the same time. The same investigator group went on to examine the renal tropism of SARS-CoV-2 and its association with acute kidney injury. So this is, again, a post-mortem series what you can see is that in this postmortem series of 63 biopsies, 60% of patients had detectable SARS-CoV-2 in the kidney. They're the darker brown color, and they're represented throughout as sort of the positive kidney. 40% of this postmortem series did not have detectable SARS-CoV-2. You can see in panel C the very strong association of acute kidney injury with SARS-CoV-2 positivity. So amongst patients with acute kidney injury, you can see that 23 of the 32, in fact, had detectable SARS-CoV-2 in the kidney uh, uh, during this study. Finally, I just want to highlight that we can't cover all of the causes of acute kidney injury in this talk. There have been case reports of even rarer causes of AKI in this patient population, and this is a AJKD letter describing 2 patients with renal infarction, shown here in dark gray. You can see that in patient 1 who had a kidney transplant, the area of infarct was very significant and led to significant renal dysfunction. And so keep this in mind in this disease, which we know is characterized by the presence of microthrombi and potentially more thrombotic complications than other forms of critical illness. So I'll stop there. Thank you for your attention and summarize. Over the last 30 minutes or so, I've shown you that acute kidney injury in the context of COVID-19 may be mediated by other factors other than direct viral involvement, including our usual critical care suspects, as well as microvascular thrombosis, possibly TMA. We've focused a lot on collapsing glomerulopathy, which also highlights the potential vulnerability of some of our patient populations to renal dysfunction in the context of COVID-19. And finally, I've shown you some data that renal tropism may correlate with clinical outcomes. I'll stop there and thank you very much for your attention.
It's a great honor to contribute to the ASN Kidney Week. In the next 30 minutes, I will focus on the impact of COVID-19 on critical care. These are my disclosures. They have not affected what I'm going to say. There is no doubt that COVID-19 has had a huge impact on critical care. In some hospitals, the ICUs have been overwhelmed by the number of patients. And this has led to capacity problems and shortages affecting drugs, consumables, and equipment. COVID-19 is a new disease, and all of us have had to learn rapidly how to look after patients and how to address the nuances of this illness. This has meant that some of our usual protocols and guidelines were not effective and had to be modified or changed accordingly. For staff caring for patients with COVID-19, it has been challenging due to changes in the work environment and wearing PPE. We've learned a lot during this time as a result of information sharing and data gathering and clinical research. And this has clearly led to a better understanding of this new illness, but it has also, in some situations, led to controversy and confusion. It needs to be remembered that staff caring for patients with COVID-19 have at times found it upsetting and distressing. And some colleagues have had serious ethical and moral concerns. Furthermore, some colleagues have been directly affected by COVID-19, and sadly, some of our colleagues did not survive. And again, this contributed to the upset and distress at the bedside. There have been additional challenges due to external factors, for instance, sudden interruptions in usual supply chains, or changes in national policies. It should also be acknowledged that the care of non-COVID patients has been hugely affected by the pandemic. In a lot of hospitals, elective procedures were either changed or sometimes cancelled completely. The provision of chemotherapy and radiotherapy has changed, all affecting the management of patients with serious non-COVID illnesses. And lastly, the way we communicate with families and friends of patients has changed in the last 6 months. A lot of hospitals have tied visiting hours or visiting restrictions so that communication is limited to phone calls or Zoom meetings. And again, we had to learn how to do this well and effectively. Capacity is clearly a big issue and affects healthcare systems differently. There are differences across the world, as illustrated here by this figure, which shows the number of hospital beds per 1,000 people. And you clearly see differences which will affect the way COVID patients are managed and allocated. This is particularly relevant for intensive care units, where we have differences in the number of beds between countries, with Germany having the highest number of ICU beds per population compared to Portugal with the lowest number of ICU beds. And clearly ICU capacity determines where critically ill COVID-19 patients will be cared for and what expansion plans look like. In cases where capacity is reached, shortages have occurred, and some of these shortages affect routine therapies and routine procedures. Some hospitals reported shortages of essential painkillers and sedatives. Other hospitals were affected by a shortage of dialysis fluid and consumables. And some hospitals reported being at a crisis point, which resulted in difficult conversations and discussions about triage allocation. These shortages will have also resulted in alternative management strategies and conversion to sometimes inferior therapies with more adverse effects. Undoubtedly, the working environment has changed, and we've all had to learn to care for patients in more crowded environments, sometimes in non-ICU areas, plus providing care with PPE and limited resources. PPE in particular has made communication difficult and has made it difficult to listen to alarms at the bedside. There's large variation in the epidemiology of COVID-19. For instance, we have some reports suggesting that acute kidney injury was not really a problem in patients with COVID-19, as suggested by this report from China, and other reports highlighting that hospitals were overwhelmed by the number of patients with acute kidney injury and reached crisis point. Some of these differences may be due to local factors and the way healthcare is managed and provided. But it is possible that some of these differences are also due to the illness itself. SARS-CoV-2 virus binds to ACE2 receptors, and ACE2 receptors are present on most organs, as illustrated here, in particular kidneys, heart, and lungs. As elegantly outlined by Pan and colleagues, there are genetic differences in ACE polymorphism and SARS-CoV-2 susceptibility. As demonstrated here, you see some of the differences in the ACE polymorphism between people from Western countries compared to the Asian population. All of this will contribute to the heterogeneous clinical picture seen with COVID-19 and differences in the epidemiology. Our understanding of the pathogenesis has improved significantly in the last 6 months, which has directly impacted the way we care for patients and manage them. In particular, we've learned that COVID-19 is a procoagulant illness with a high risk of thromboembolic complications and a high risk of pulmonary emboli. And so in a lot of places, the approach to anticoagulation has changed as a result of an improved understanding of the link between inflammation and thrombus formation. Similarly, we've learned that COVID-19 associated pneumonitis is different from standard ARDS and therefore may warrant a different management approach. In a lot of places, COVID-19 associated pneumonitis was initially treated like ARDS with a high PEEP approach and tight fluid restriction. But these papers here highlight that this may not be the right approach and that COVID-19 associated pneumonitis may be very heterogeneous with different clinical features different from ARDS. And as a result, the management may also have to be changed and altered. And clearly this is what has happened in the last 6 months. A lot of colleagues have changed their approach to ventilation, their approach to fluid management, and the way they prevent thrombi and thromboembolic disease. A lot of colleagues have implemented systemic anticoagulation for patients at high risk. And lastly, our understanding and our management has changed in response to rapid clinical trials, in particular the remdesivir and steroid trials. The remdesivir trial was a randomized controlled trial comparing intravenous remdesivir for 10 days with placebo in patients with COVID-19 and lower respiratory tract involvement. The primary endpoint was time to recovery, and the trial showed that patients randomized to remdesivir recovered faster. Their time to recovery was shorter. As a result, remdesivir has been incorporated in the management protocols of a lot of hospitals. More recently, the results of the recovery trial were published. This was a randomized controlled trial comparing dexamethasone with placebo in combination with usual standard care for patients with suspected or confirmed COVID-19. Patients were randomized to dexamethasone for up to 10 days versus placebo. And as demonstrated here on your left at the top, there was a significant difference in 28-day mortality. Patients randomized to dexamethasone had a significantly lower 28-day mortality. Subgroup analysis confirmed that the effect was relevant for patients who were on invasive mechanical ventilation or oxygen therapy at time of randomization. In these cohorts, dexamethasone resulted in a lower 28-day mortality. In contrast, patients who were not on any oxygen treatment at time of randomization benefited more from usual care. And in this group, as shown here on the right at the bottom, treatment with dexamethasone led to a higher 28-day mortality. These results are very important and clearly determine how we manage COVID-19 in the next waves. All of us will have had the feeling that we've learned a lot and that there are things we would do differently in the next wave. Peter Pickers and colleagues summarized this in a recent article and highlighted 10 areas which were areas where they had clearly changed clinical management and wished they had had the knowledge a few months ago. And these 10 areas include some of the issues which I highlighted earlier, in particular, the acknowledgement of hypercoagulation, the changes related to mechanical ventilation, and a better understanding of potential drug therapies. In a lot of places, the management of acute kidney injury proved to be very challenging. And a lot of hospitals across the world ran out of renal replacement therapy capacity. We certainly have reports in the literature from New York and the UK and many other places where renal replacement therapy capacity was reached and crises point were met. And these crises were due to many factors. Firstly, there was obviously a large number of patients who needed renal replacement therapy, plus the duration of renal replacement therapy proved to be longer compared to critically ill patients not suffering from COVID. And therefore, the total number of patients on renal support in the ICU increased. Caring for patients who needed renal replacement therapy was more challenging, and other management aspects impacted the provision of renal support. For instance, the need for proning had an impact on the modality and choice of renal replacement therapy. And then there were direct factors which impacted renal replacement therapy provision. As a result of the procoagulant nature of COVID, a lot of hospitals saw that usual anticoagulation strategies did no longer work. They experienced shorter filter life. A lot of hospitals also faced shortages of consumables and limitations of their resources and availabilities. And for staff who were asked to provide renal replacement therapy, it was more challenging, in particular when working in PPE. Finally, in some places there was less staff available, and the staff who were asked to provide renal replacement therapy was less well trained. And the increase in workload was combined with a need for data gathering, auditing, and collaboration in clinical research. In recognition of these challenges, the AKI steering group called an AKI meeting in June 2020 to summarize the existing data and to provide some recommendations for future practice. With regards to renal replacement therapy, the expert group recommended that there was no optimal modality for renal replacement therapy. And based on the existing data and the existing experience in the team, the group recommended that the selection of modality should be based on patient needs, local expertise, and the availability of staff and equipment. They acknowledged that the selection of modality may change during the course of the illness, as it may be affected by supply problems, machine availability, and availability of appropriately trained staff. But in principle, it was felt that all types of renal replacement therapy had a role potentially and should be considered in a pandemic, including modalities which are less frequently used, like acute PD. The team emphasized the need to reduce waste, including the recommendation to focus on filter life and extend filter life as much as possible. To this effect, they suggested to use continuous hemodialysis or continuous hemodiafiltration to decrease the filtration fraction and to reduce risk of circuit clotting in situations where continuous renal replacement therapy was used. They strongly recommended to have an anticoagulation strategy in place to reduce filter clotting and to have a clear plan how to escalate anticoagulation in a stepwise manner if necessary. A potential anticoagulation strategy may look like this. As outlined here, the team recommended that clinical teams started with their local protocol and then escalated as necessary depending on the performance and data from their usual monitoring. And if necessary, local strategies could be stepped up to second line or even third line anticoagulation strategies. It's important to remember that anticoagulation is clearly necessary, but should not be considered in isolation. And anticoagulation can only be effective when combined with good vascular access. With regards to vascular access, there are no particular recommendations for COVID-19 patients, and the previous recommendations, as outlined here, still hold and are applicable to patients with COVID-19. In summary, patients considered for renal replacement therapy should receive an appropriately sized catheter of appropriate length, depending on the insertion location. The AKI expert team recognized that the response to renal replacement therapy needs may vary depending on location, but also depending on the time point during the pandemic. And they developed this algorithm, which is applicable to patients with COVID-19, but also applicable to any other pandemic or disaster situation. And I'll take you through this in more detail. It was recognized that there may be situations where renal replacement therapy provision is in crisis, either as a result of an increased demand, an increased use, or reduced capacity. In this situation, the response is variable and depends on the circumstances. In situations where there is still time for preparation, the focus should be on training and potential stockpiling. During this time, it's necessary to be prepared for a potential surge, to train staff, and to have protocols in place for potential escalation. During the pandemic, or at peak, it is necessary to maintain availability of renal replacement therapy to everybody who needs it. To do this, the provision of renal replacement therapy should be optimized, including auditing and monitoring of the treatment and consideration of alternative strategies. And during this time, it's also important to reduce the number of patients needing renal replacement therapy and to focus on prevention of acute kidney injury and optimization of non-dialytic strategies. Clearly, at this point, it's necessary to collaborate well within the department, but also with colleagues outside the department whose expertise may be required, and colleagues within the region and at national level. At peak, or when capacity has been reached or exceeded, the aim should be to provide the greatest good for the greatest number. And at this point, discussions about triage, allocation, and resource allocation may be necessary. And at this point in particular, it is necessary to collaborate with national institutions and national authorities. So in summary, there is no universal solution for renal replacement therapy in COVID-19 because the circumstances may change rapidly. And it's necessary to be prepared and also to be flexible, to be prepared to adopt alternative strategies quickly, sometimes with very little notice. And in my opinion, the most important tools to get through this crisis are to share experience, to work with colleagues and to collaborate and to share the existing expertise and knowledge. As I've already alluded to, our approach to COVID-19 has changed significantly in the last 6 months. Colleagues from IGNAC here in the UK summarized this in a recent paper. And as you can see here, as we gathered knowledge and improved our understanding, the number of patients receiving invasive ventilation reduced throughout the pandemic in the UK. Similarly, we saw a slight trend in the provision of renal replacement therapy, with a reduction in the proportion of patients who needed or were started on renal replacement therapy. This development occurred in parallel with an improvement in outcomes. In the beginning of the pandemic in the UK, we were alarmed by mortality figures of around 80%. But throughout the pandemic, this slowly improved to mortality figures of less than 60%. And clearly, this is a reflection of our improved knowledge and changes in overall clinical management. So in conclusion, I hope I've convinced you that COVID-19 is a heterogeneous illness which presents many challenges to intensive care units in all parts of the world. During the first wave, our clinical approach changed in response to learning information sharing, and a better understanding of this illness. With regards to renal replacement therapy, there is no universal solution, and clinicians are asked to adopt new management strategies in response to potential shortages and capacity problems. Clearly, collaboration with colleagues in and outside the unit is essential, in particular collaboration with colleagues in the renal department. And based on our preliminary data from the UK, it appears that the overall outcome of this patient population has improved, including the outcome of patients with severe acute kidney injury. Thank you very much for your attention. It was an honor to present these data.
Welcome to all of the Kidney Week participants who are joining today for this presentation. I wanted to thank the ASN for inviting me to speak today, and I wanted to thank the moderators for putting this session together. I also wanted to thank all of you who are watching this session during our virtual Kidney Week. My name is Miran Naljayan, and I'm a clinical associate professor of medicine at the LSU School of Medicine in New Orleans. I'm also the Vice President of Clinical Affairs for Home Modalities at DaVita Kidney Care. And it is my pleasure to present peritoneal dialysis for acute kidney injury today. This is my disclosures. And here are the objectives of my talk today. We're going to go through the history of AKI and then talk through a couple of studies as well as how COVID-19 and AKI impacted dialysis in the United States, and give some examples of how PD for AKI was used here in the US and other parts of the world. Let's first start with AKI for PD. This is not a new therapy. Some of the first described cases of using PD for AKI was in the 1940s. But with the advent of the central venous catheter and newer technologies like hemodialysis and CVVHD, many areas of the world were less likely to use PD and instead started utilizing these newer therapies. But there are still other parts of the world, particularly in developing parts of the world, where PD is commonly used for AKI, partly due to the fact that this is a lower cost therapy and also due to the limitations in supplies for the other types of therapies. In one study, ISPD delegates were surveyed, and 36 to 50% of them felt that PD was an appropriate therapy for AKI in the hospital, yet only about 15% of them actually utilized it themselves. This highlights the large discrepancy that exists amongst nephrologists who feel that PD is an appropriate therapy and yet is not commonly being used across the world. There have been few studies looking at outcomes comparing PD for AKI and other modalities. For example, in 2008, Gabriel and colleagues published a study from Brazil where they performed a prospective randomized control trial of 120 patients in the hospital with ATN, where one group received high volume peritoneal dialysis every day and the other group received daily hemodialysis. The authors concluded that there were no significant differences between metabolic parameters and ultrafiltration between the two types of therapy, but they did find that those patients on PD had a shorter time to recovery of their renal function as compared to hemodialysis. In another randomized controlled trial of 125 ICU patients in Saudi Arabia, Al-Hawayshia and colleagues found that continuous PD for AKI had better outcomes than CVVHDF for patients in the ICU. The authors found that patients had improved mortality, lower infection rates, more recovery of AKI, and a shorter length of ICU stay. Now, I'll admit, these aren't very large studies, and as we all know with all AKI trials, there are some confounding factors that may exist, but the data is surely compelling and should have all of us thinking about this on a broader scale. Could PD be used for AKI safely more commonly across the globe? As I mentioned, PD for AKI is rarely used in the United States, and there are a few reasons this likely exists. First, many nephrologists don't feel comfortable with PD for ESKD, much less for AKI. Also, many nephrologists and intensivists are not necessarily comfortable with PD for things like metabolic control and ultrafiltration control in critically ill patients. Also, many hospitals have limited nursing capability to do PD, and in some hospitals, PD is not even an offered therapy, even if a PD patient lands up in that hospital. There's also variable surgeon expertise on placing PD catheters, and therefore, even in AKI PD, this would be highlighted and limited. CMS now reimburses providers for outpatient dialysis for AKI, but only for hemodialysis as of last year. Peritoneal dialysis is not reimbursable. Therefore, if a patient was to receive AKI for PD and needs to transition to an outpatient facility, there would be no way to get coverage for that patient. There are only very few payers in the United States that currently reimburse providers for PD for AKI. Also, as we think about the continuum of care from the inpatient to the outpatient setting, a patient who receives PD as an AKI should also receive inpatient modalities education as well as a home visit to ensure the patient is a suitable and safe candidate to go home on PD. This is not uniformly done in all hospitals around the country, even for our ESKD patients, much less for our AKI patients. And of course, although urgent start PD is getting more common across the United States, not all outpatient PD centers have the capability of doing low volume supine dialysis. So for patients with AKI PD, this may not be an option if their local PD center does not offer this type of therapy. With that in mind, let's shift gears to see how COVID-19 impacted AKI and thereby changing the landscape of dialysis. Based on data from various parts of the world, AKI rates did vary, with much higher rates of AKI reported in the United States than in initial reports from China. Depending on what study you read, you'll find that rates of AKI were up to 1/3 of COVID-19 patients, and about 15% of them required dialysis. What's even more striking is that in one study, approximately 90% of ventilated patients developed AKI, many of whom required dialysis as well. And as we saw in the parts of the country that had significant impacts from COVID-19 with surge rates that were quite difficult to control, dialysis shortages did occur. And this was due to things like machine shortages, tubing shortages, fluid shortages, as well as nursing shortages. Now, in the hospital, there are different types of therapies that currently exist to provide kidney replacement. For the unstable patient, the most commonly used therapy is CVVH or CVVHD. And in this type of therapy, we have continuous removal of solute and urea as well as ultrafiltration, and we're able to dial in exactly what we want hour by hour. So this is highly helpful for patients who are hemodynamically unstable, but it does require a CVC placement. One limitation of CRT is that it's not available in all hospitals, and they're usually run by the ICU staff. And so in areas where ICU staffing shortages occur, this modality suffers. Also, as we learn, in patients with COVID-19 who become hypercoagulable, CRT becomes increasingly difficult due to that hypercoagulable state. PIRRT, or prolonged intermittent renal replacement therapy, can also provide these types of longer times of urea, solute, and ultrafiltration, but also requires a catheter and can be utilized for hemodynamically unstable patients. This allows for shift-based therapies to occur, particularly in times of shortages. But this still ends up with a limited number of machines, may require an RO system depending on the type of machine utilized, and also may require ICU or dialysis nurses to operate. Again, patients who are hypercoagulable may have difficulty with this type of therapy due to clotting of the filters. Intermittent hemodialysis is more ubiquitous amongst almost all hospitals across the country, and most people feel comfortable with the type of therapy and requires a CVC placement. But this therapy is not routinely done for patients who are hemodynamically unstable because it is much more difficult to do in those cases, and it requires a specialized hemodialysis nurse to provide care. It also likely requires a portable RO, which may be in limited supply, as well as the machines. PD can be utilized both with cycler-based therapies or manual-based therapies, and can be done continuous or intermittent, and can be utilized for the hemodynamically unstable patient. And for those patients who are hypercoagulable, PD does not have issues with catheter problems from that. But it does require a dialysis nurse generally, or staffing within the hospital who understand how to do PD. And it also requires surgeon or interventionalist placement of the PD catheter into the peritoneal abdomen, something that is more difficult to do than a central venous catheter, for example. Also, it's not easy to do in patients who are in the prone positioning, particularly with ventilatory issues in the COVID-19 population. I'd like to review what we experienced in New Orleans, and LSU and Tulane both share University Medical Center in New Orleans. As many of you are aware, New Orleans experienced a rapid rise in the cases of COVID-19 starting in the middle of March, and we were significantly impacted by this disease across our region. By looking at our data between March 9th and March 30th, we found that of the patients admitted with COVID-19, almost half developed AKI, and about 15% of those patients required some type of renal replacement therapy. 80% of our ventilation patients developed AKI, and of those, over 1/3 of them required some type of renal replacement therapy. When we looked at our data between March 15th and April 15th compared to the same time last year, we saw a 47% increase in the number of inpatient dialysis treatments and a massive 262% increase in the number of CRRT treatments across the New Orleans metropolitan area. We also struggled with hemodialysis nursing shortages, as well as ICU nursing shortages, as well as ICU rooms requiring rapid expansion amongst all the hospitals to accommodate for the number of patients requiring ICU level of care. Because of these shortages, we developed the LSU acute PD protocol, utilizing some of the guidelines previously published. And we also held a virtual meeting with all nephrologists in the city of New Orleans and shared that protocol with our colleagues so that in their hospitals, they're also able to use PD when shortages occurred of the other types of therapies. In order to do PD successfully for AKI, we need to have a clear process in place in the hospital. So in order to do this, a pathway is required, and the first step is appropriate patient selection. Now, patients both in the ICU and the floor can do AKI PD, as will be demonstrated in the next few slides. But things to really note are that if patients require prone ventilation for prolonged periods of time, or an acute abdominal infection, for example, they would likely not be candidates for AKI PD and would be better suited by one of the other modalities. But beyond that, most patients can tolerate AKI PD, and the first step would be the peritoneal dialysis catheter placement. The placement of the PD catheter is extremely important in order to be successful from day one. What's required generally is a flexible, ideally tunneled PD catheter, which can be placed in a percutaneous fashion or with laparoscopy or a laparotomy. And what's really important is to utilize the expertise of the center placing these catheters. It can be done in the ICU via the percutaneous method, or if the patient is stable enough to go to the operating room, can be placed in the OR. Some places, depending on what catheters are available, a rigid catheter may be used, but just like for our ESKD, peritoneal dialysis catheter placements, perioperative antibiotics are important to help prevent peritonitis. There are a lot of online resources available for our surgeons and interventionalists to understand how to place these catheters and utilize those best demonstrated practices in all of the various modalities outlined. I have a couple of them listed here, and if you do a quick Google search, you'll be able to see them online. After the peritoneal dialysis catheter is placed, the next step is to ensure that our prescription meets our goals, which are adequate solute clearance and adequate ultrafiltration. PD can either be performed with a cycler or with manual exchanges, although cycler may be easier in the hospital, especially when trying to dialyze for either 12, 18, or 24 hours. The cycler also requires minimal nursing utilization and can be set up daily and can even be set up outside of the patient's room with extension tubing, as seen here in this photo for one of our patients. This will allow nurses to be able to change the fluids or check data off of the machine or troubleshoot anything without actually having to go into the isolation room very frequently. It's important to ensure that the patients have an adequate bowel regimen, as having regular bowel movements is very important to both clearance and ultrafiltration. It's also important to keep the patients in the supine position to minimize pericatheter leak. Initial volume should be somewhere between 750 ml to 2 liters depending on body surface area, and this can be done immediately after peritoneal dialysis catheter placement. The initial dwell times generally are relatively short, between 2 to 3 hours. Once we achieve adequate metabolic control, we can then increase those dwell times to between 4 and 6 hours, depending on the total continuous time of therapy. There are some complications that we need to be aware of. First, pericatheter leak. Anytime placing an urgent start catheter and utilizing it within that first 2-week period does increase that risk for leak. But by doing low volume supine dialysis, we can minimize it. But should you notice a pericatheter leak, hold the PD for 24 hours, and then you can restart it again and see if there's further leak. If there is, I would suggest holding it for a longer period of time as long as the patient continues to remain safe. If not, utilizing another type of therapy. Of course, peritonitis is something we always want to prevent, and as I mentioned, perioperative antibiotics is very important, but also utilizing all the protocols and techniques that we use in the outpatient dialysis setting to minimize infection is paramount. Catheter dysfunction is probably the most likely complication you may encounter, and it's important to have a healthy bowel regimen, as noted earlier, and to dwell heparin in the dialysate bags to help prevent fibrin clotting that catheter. If necessary, the patient may need to go to the operating room for a surgical revision of the PD catheter. Hypokalemia is very common in patients on PD, and especially for AKI PD, where we may be using it continuously without potassium in the dialysate, hypokalemia may be very prevalent. This can be easily replaced using an oral or intravenous protocol, or depending on hospital procedures, can be done intraperitoneally. Using dextrose-based solutions may increase the risk for hyperglycemia, and this can be managed by using insulin per hospital standard protocols. And of course, PD can lead to protein losses, although there have been studies that have evaluated that protein loss and did not significantly increase the risk for hypoalbuminemia. But this is something we should be monitoring for, especially given these patients are ill, and if needed, switch therapies for that hypoalbuminemia if present. Here's a sample protocol we published earlier this year in Kidney 360 with colleagues from across the US and Canada. By outlining a sample protocol like this, we hope other institutions are able to develop a protocol that fits their needs and processes in order to offer PD for AKI patients at their hospital. You can see we've outlined some of the monitoring that should happen on a daily basis to ensure we're meeting our goals and some of the replacement that may be necessary. We've also outlined those complications I just listed earlier. And we also have a couple of sample prescriptions. Of course, there may be some differences that exist based on requirements within each of our institutions, but I think this is a good place to start if you're considering adding this to your repertoire of dialytic therapies at your hospital. Now let's talk about COVID-19 and the AKI PD experience that was noted across the globe. In New York, an area that was hard hit by the pandemic, there were 3 published studies that talked about their experience with AKI PD. Montefiore Medical Center reported 30 patients that underwent AKI PD, and of those, 14 of them died, 8 were discharged, and 8 were still hospitalized at the time of their publication. They did highlight some of the limitations that existed, particularly around training, both for themselves and the nurses, supply availability, and the ability to achieve adequate solute clearance and ultrafiltration. Another report out of New York City had 11 patients that received PD for AKI. 4 of those died, 6 of them recovered, and 1 remained dialysis dependent. Mount Sinai also published a paper where they discussed their 10 patients who received PD for AKI. There was 1 published case from Japan who were successfully treated with PD for AKI. There was an ISPD webinar from a few months ago where we discussed not only our experiences in Louisiana, but also our colleagues from the United Kingdom described their experiences utilizing PD. And our experience, of course, in New Orleans, we had 18 patients across 3 hospitals ultimately utilizing PD for AKI. 2 of them recovered renal function. 1 is still on outpatient PD. 1 is on outpatient hemo, and 14 of them died. Of note, those that did die did not necessarily die due to complications of peritoneal dialysis or inadequate solute or volume clearance, but rather just due to the multi-organ failure from COVID-19 that existed. We had many patients pass away, unfortunately, despite the modality of therapy utilized. As we start to think about continuous-based therapies and then transitioning them to intermittent-based therapies, particularly into the outpatient setting, we should also consider what impacts exist from these different therapies on the likelihood of a patient's renal recovery. In a study published last year, Marantz and colleagues showed evidence of decreased renal perfusion as seen here on these images, and they also have studied decreased myocardial perfusion and myocardial stunning that exists from that. There was a study that had been published previously looking at myocardial stunning, and PD was not actually associated with that. Partly this may be due to the fluctuations in volume in the intravascular space and intradialytic hypotension that may exist with intermittent-based therapies. There are also studies looking at the impact of PD versus intermittent hemo on the preservation of residual kidney function for patients with ESKD. And the PD definitely preserves better than intermittent hemo. So with that being said, especially for patients who have severe AKI or who may have started with some type of continuous base therapy, as we think about transitioning them across modalities, it seems that it may be likely that PD has a renoprotective effect and has less influence on hypoperfusion to the kidney and may lead to better rates of recovery of AKI. Now, more studies are needed in this field, but I've highlighted a couple of earlier studies from Brazil and Saudi Arabia that also have these similar findings. And so as we look forward, we may want to think about that continuum of care from the inpatient to the outpatient setting and whether transitioning patients onto PD for AKI and maintaining outpatient PD for AKI may help them get their recovery and come off of dialysis. Clearly, as evidenced by my discussion thus far, we need a lot more research in this field. First, we need large, randomized, multi-center, prospective controlled trials that evaluate outcomes between PD, intermittent hemo, and CVVH or CVVH-DF. But not just on outcomes like mortality or recovery of renal function or ICU length of stay or cost, but patient-centric outcomes such as how's their quality of life after they transition into the outpatient setting on dialysis, or the environmental impacts of the various types of therapies that exist. We also need to educate not just ourselves as nephrologists and nephrology community, but also our intensivist colleagues so they can also understand the benefits of PD and that it can adequately provide solute clearance and ultrafiltration for patients in the hospital with AKI. We need to educate our surgeon partners and our intensivist colleagues so that they're utilizing those best demonstrated practices on PD catheter placement so that that PD catheter is functional on day one. If that PD catheter doesn't function, then this therapy cannot be utilized anyway. We also need to work with our legislature to make changes in our regulations in order to accommodate PD for AKI, just as we did a few years ago and got them to change HD for AKI in the outpatient setting. We also need to work with our LDOs and our other dialysis providers to support AKI PD in the outpatient setting and help provide that education needed for patients in order to make the modality choice that's right for them. In conclusion, hopefully I've shown you that PD for AKI is not new, but rather is back in the spotlight again as COVID-19 impacted nephrology and dialysis and showed us where we are limited in our capabilities to care for patients. We should be able to offer the entire spectrum of kidney replacement therapies for our patients while ensuring excellent clinical outcomes with a focus on patient safety and developing processes in hospitals on outpatient dialysis units around PD for AKI. Thank you for your time today, and I'm happy to answer any questions in the chat box. Enjoy the rest of your virtual Kidney Week experience.
Thank you, Doctors Kathleen Liu, Marlies Osterman, and Miran Naljan for wonderful presentations on COVID-19 and acute kidney injury. It's really been an eye-opening experience for all of us as we endured this pandemic and taken care of so many patients with COVID-19 in the ICU. Learning about the pathophysiology and how intensivists and nephrologists tackled this surge of patients in the ICU is fascinating, and also learned a lot about acute PD from Dr. Naljan. Acute PD is something that we don't usually do in United States for adult patients with acute kidney injury. So overall, this has been an extremely informational session for all of us. I would like to thank my co-moderator, Dr. Hung, and I would also like to acknowledge American Society of Nephrology, especially all the organizers from ASN who has worked tirelessly during the past couple of months in putting together such a great program for Kidney Week 2020 Reimagined. I would like to thank the audience for tuning in today for this SimuLive session, and hope that you continue to enjoy and participate in the rest of the meeting. Thank you again for joining in, and thank you, everyone. Have a great day.